Hi everyone, I am Brianna, and today I'll be talking to you a little bit about Tourette's disorder, which we commonly refer to as Tourette's syndrome. So, what exactly is Tourette's disorder? It was named for Dr. Georges Gilles de la Tourette, who first coined it in 1885 as maladie des tics. He insisted that it was different than chorea and hysteria. So we know that Marquise de Dampierre, a French noblewoman, was notorious for publicly shouting out in the middle of conversations and shouting out inappropriate or obscene words. And Marquise was Dr. Tourette's patient. Like I mentioned before, we commonly refer to it as Tourette's syndrome. It is commonly considered a genetic disorder as well. So, what is Tourette's disorder exactly? It is a neurological disorder characterized by involuntary movements and vocal tics. A tic is defined as a sudden, rapid, recurrent, non-rhythmic motor movement or vocalization. In the DSM-5, we are told that tic disorders as a whole are in a hierarchy, having Tourette's syndrome as the most severe, then persistent motor or vocal tic disorder, and lastly having provisional tic disorder. It is important to note that once a tic disorder is at one level of the hierarchy and is diagnosed, a lower hierarchy diagnosis cannot be made. So here are some models on the origin of what was believed to be Tourette's syndrome. So first, the neurobiological model states that Tourette's syndrome and tic disorders are an inherited developmental disorder involving an imbalance in the dopamine pathways in the brain, most likely involving the basal ganglia. Next, we have the psychoanalytic model, which considered tics to be sexual in nature. Mahler and Luke suggested tics as erotic and aggressive instinctual impulses which are continually escaping through pathological discharge. And lastly, there is the behavioral model, which state that tics are conditioned responses that will be performed whenever new sensations appear. So the DSM-5 diagnostic criteria for Tourette's disorder is as followed. Criterion A states that both multiple motor and one or more vocal tics have been present at some time during the illness, although not necessarily concurrently. B, the tics may wax and wane in frequency but have persisted for more than 1 year since the first tic onset. Criterion C is that the onset is before 18 years old. And lastly, D, the disturbance is not attributable to the physiological effects of a substance or another medical condition. So what do these symptoms look like? For Tourette's disorder, they have simple versus complex symptoms. A simple tic affects one or just a few parts of the body, such as blinking, making faces, shrugging your shoulders, for example. A complex one, on the other hand, involves many parts of the body and are in concurrence with vocal tics as well. So, for example, this can be eye blinking and coughing. So, motor tic symptoms are, for example, eye blinking, head shaking, arms jerking, or shrugging, whereas vocal tic symptoms are barking, hissing, utterance, coughing, etc. So, some tics can present themselves as follows. There's coprolalia, which is excessive and uncontrollable use of foul or obscene language, which is what most of us usually think tics look like, which is how the media portrays it most of the time. But in reality, around 10% of people with Tourette's syndrome present these type of tics. Next, we have echolalia, which is repeating the words of other people. There's copropraxia, which is tic-like sexual or obscene gestures. Echopraxia is tic-like imitation of someone else's movements, and palalia is repeating one's own words. So the onset of the tics is between 4 and 6 years old, with a peak severity between ages 8 and 12 years old. So every source varies. There's 8 to 12, you'll see 8 to 12 years old, 10 to 12, but it's somewhere in that range. It is stated that 1 in every 160 children have Tourette's, and that males are more affected than females, around 3 to 4 times more likely. The first tics are usually motor tics, which affect the head and neck, And as children get older, they report tics being associated with premonitory urges, which are somatic sensations that precede the tic, followed by tension reduction. So once this tic is fulfilled, the individual feels a sense of relief. Individuals may just need to perform the tic until he or she believes it has been done just right. The just right concept is something that we see as well in patients diagnosed with OCD. So individuals that have mild to moderate symptoms have less impairment and distress than those with severe symptoms. So tics tend to decrease during adolescence and early adulthood. Some individuals may have tic-free periods of weeks or even months. Tic onset is uncommon in teenagers and adults, but if they present initial symptoms when older, it usually dates back to their childhood and maybe they just didn't catch it at first. Tourette's disorder is a lasting disorder. It is not a degenerative condition, and those patients diagnosed with it usually tend to have a normal life expectancy. Some risk factors are temperamental factors. Tics worsen by anxiety, excitement, or exhaustion. And when the individual is calmed or focused on activities, tics seem to minimize. So an example of this could be when, let's say, a young adolescent is focused on schoolwork or doing homework or is hanging out with their friends, the tics seem to be less. Then we have environmental factors. The environmental factors, which is observing another person's gestures or sound, may cause onset of the tics on the individual. Next, there is genetic and physiological factors, which influence tic symptoms expression and the severity of the tics. So we have, for example, older paternal age, lower birth weight, maternal smoking during pregnancy are associated with tic severity. So there is no single test for assessing Tourette's disorder. Physicians must differentiate Tourette's syndrome from another tic disorder, making sure that they have both motor and vocal tics. The doctor may perform tests to rule out other diagnoses, so they won't rule Tourette's disorder when in fact it is something different. So some cultural considerations that we have to take into account is that Tourette's syndrome occurs in all ethnic groups, but they found that it was lower among African American and Hispanic Americans. The characteristics of the tics are not seen to vary by race or ethnicity, so all tics present themselves the same in all races and ethnicities. The aspect that seems to be different is the family and community reactions. So it is noted that an individual's race, ethnicity, or culture may impact the way their family and community perceive and manage the disorder, which as well affects the individual's access to care. So there is no cure for Tourette's syndrome, and the no medication eliminates symptoms completely. It only helps relieve them. Medications do have side effects such as sedation and weight gain. Some of those medications are listed below, such as antipsychotics. One thing to note is that many of these medications are used to treat something else, but by treating the other disorder, it helps regulate the tics, so it won't be as impairing in their lives. Then we have cognitive behavioral therapy, which teaches people how to manage their tics and is useful for comorbid treatments. Next, we have comprehensive behavioral intervention for tics, and this is training voluntary movements in order to manage a response to the tic symptoms. An example of this is habit reversal. So first we have awareness training, in which the individual identifies the tics that they are experiencing, and then is followed by competing training. So an individual learns an action in place of the tic. Lastly, we have supportive therapy, in which the clinician teaches coping and relaxation skills in order to deal with the tics. Tourette's disorder is highly comorbid with OCD and ADHD, but listed are a few more co-occurrences such as depression, substance abuse, conduct disorder, personality disorders, anxiety disorders, and sleep disorders. Above, we have some differential diagnoses such as substance-induced and paroxysmal dyskinesia. Next, we have myoclonus, which is characterized by sudden unidirectional movement that is often non-rhythmic. So it's pretty similar to Tourette's disorder, but what's different about it is that the tics are different in its rapidness, the lack of suppressibility, and the absence of premonitory urges. Lastly, we have obsessive compulsive disorders, but the difference between obsessive compulsive disorders, and Tourette's disorder is that the repetitive behaviors appear more goal-directed and complex than tics. So, for example, with obsessive compulsive disorder, there's a goal in mind, whereas tics is just like the relief of completing the tic. So here we have a short case study. John is a 13-year-old middle school student who has a history of blinking, shoulder shrugging, vocalization, and whistling. He was presented to the school counselor and reported a history of 4 years of involuntary symptoms. John shared that the symptoms would be less intense during the summer, especially when he kept busy with physical activities. But when he experienced exhaustion, anxious feelings, or sat idle for an extended period of time, his symptoms would worsen. John was only able to suppress his tics for a few minutes at a time, but his tics were connected to stress and anxiety. John has developed other symptoms as he has gotten older, which include smirking and tapping of his foot. His tics has made it uncomfortable for him and his parents when going out in public and has caused John irritation throughout his day. So here we see that John meets the diagnostic criteria that is presented in the DSM-5. He is 13 years old. He presents motor tics such as blinking, shoulder shrugs, and vocal tics such as whistling. He has been presenting symptoms for 4 years, and they are less intense during the summer because he is less stressed and is busier with physical activities. But his tics would worsen when he experienced exhaustion and anxious feelings. Lastly, we see the difference between simple symptoms and complex symptoms. Towards the end, it is stated that John would smirk and tap his foot. Those are two of his tics, and these would be identified as complex symptoms. A differential diagnosis that could be considered for the case presented is possibly ADHD, but I believe that his motor symptoms of tics and his vocal symptoms, as well as his complex symptoms, truly identify better with the diagnostic criteria for Tourette's disorder. It is possible that the tics being connected to his stress and anxiety may be comorbid with another disorder, but we cannot be sure of that with the information given. Here there is a video which I find to be super informative. It is a TED Talk with a lady who has Tourette's disorder, and she just gives you a little insight on it and why it does not define her. So if you have a chance, it's about 12 minutes long. I suggest it's a good watch. And here are my references. Thank you.